Good evening. Welcome to the New York Center for Head and Neck. My name is Dr. Christopher Linstrom. I'm a professor of otolaryngology, head and neck surgery, skull-based surgery here at the New York Eye and Ear Infirmary. I'm also a surgeon director here and in the continuum system. I'd like to first of all thank you for taking the time out of your schedule to join us for this webinar. Our topic this evening is hearing loss in children. And there will be time throughout the lecture for you to jot down questions, and hopefully we'll have time at the end for me to answer a few of them. Also, my e-address is on the slides and we'll project it again at the end. So if there are some questions that we can't get to or other topics, just send me an email and I'll do my best to answer it. Okay. So let's start now just by a little summary. First of all, my audience, I know, are pediatricians and professionals in the hearing and communication field. So a lot of this information you will probably already know. It's certainly topics that you deal with pretty much all the time. So in review, we'll talk about embryology and anatomy briefly, the normal function of audition, tests of hearing in children, and some will be adults as well. Congenital and hereditary hearing loss, infectious and inflammatory causes of ear disease, but this is going to be very brief. Congenital auricular atresia, which is a very important topic, and also remediation of hearing loss. There's some really exciting things going on in hearing. So let's just look over the embryology. So the ear forms from two separate and simultaneous events. The outer and middle ears form from the invagination of the first branchial arch, first and second branchial arches. They are met by the first pharyngeal pouch. So all of the derivatives come from these branchial arches and pharyngeal pouch. So the outer structures will have an epithelial derivative. So all their adnexal structures will be from the epithelium. Okay, so that means the external auditory canal up to the lateral surface of the drum. The middle surface will be mesothelium, so that's sort of the middle part of a sandwich, and the middle ear cleft will be lined by respiratory epithelium. The ossicular chain comes from the first pharyngeal pouch, and they are arch derivatives as well. One would be malleus, two would be part of incus and stapes. The inner ear structures are a simultaneous but separate event from the area of the otocapsule, the otocyst, near the notochord. It is developing by partitioning itself as it develops, and it's migrating medially to join the other structures that have formed. So it is of ectodermal origin because it's innervated. Any part of the body that becomes innervated is of ectodermal origin. Okay. Our ear has there's three parts. The outer ear is sort of a sound gatherer. The middle ear is a natural amplification system. And the inner ear translates or transforms sound from fluid waves to electrical depolarizations, which are then carried by the spiral ganglion cells to the eighth cranial nerve, up the axis to the brain stem, the higher centers of hearing, where they cross, that's a bilateral innervation, to the Broca's speech area in the temporal lobes. Now, sound as it comes into us, it loses some power. It loses about 28 decibels of sound pressure. So sound is measured in a unit of pressure, that is, force per unit area. It has to be re-amplified, and in the normal situation it is. So our auricles are like sound trumpets or sound directors to a big surface area that will eventually articulate with a very small surface area that is the footplate of the stapes. So that gives it a mechanical advantage. We have two other ossicles or levers, a big malleus, a big incus or anvil, articulating with the smallest bone in the human body, the stapes. So all of this natural conductive system re-amplifies by about 28 decibels. So we lose some coming in, we gain it back naturally. But this system can only work if we have a working eustachian tube. So the eustachian tube, which goes from the middle ear cleft to the area of the nasopharynx just by the fossa of Rosenmüller, it is closed at rest Ordinarily, with every swallow, it temporarily opens. It allows a little bubble of air to equalize or equilibrate pressure, air pressure, between the middle ear space and the external canal. And this, in the normal situation, we don't even think about, but certainly in the presence of eustachian tube dysfunction, this is really the cause of an encyclopedia of ear disease. In fact, I often ask patients, why are barbers in business? Answer, hair grows. Why are otologists like me in business? The eustachian tube doesn't work. That's the basis of a lot of pathology. And in the lower picture here, we can see that this sound pressure is then going to be transmitted through the fluid system of the inner ear, which is closed. So when sound pressure hits the base of the stapes, it must transmit through the whole modiolus and be relieved at the oval window. So it's one closed system. The inner ear will then have shearing forces based on these traveling waves through fluid, which will depolarize the cochlea and then send a tonotopic representation of sound through the spiral ganglion cells to the eighth nerve and then back up to the brainstem. Now remember that the ear is like an inverted piano keyboard. So the high tones are in the base, the low tones are actually in the apex of the cochlea. Hence, noise-induced hearing loss affects the higher tones as opposed to the lower tones. And in this picture here, we can see that in the brainstem there is bilateral representation. So sound coming to one side actually is perceived cortically on both sides. We classify hearing loss according to its location. So we typically would classify it as conductive, which means mechanical. Let's look at this ear. We can put a wad of wax here, or give the ear a perforation, or have an ossicular chain discontinuity. That would cause a mechanical or conductive hearing loss. Or we could have something go wrong with the cochlea itself, such as presbyacusis, or hereditary hearing loss, or noise trauma. That would be a cochlear cause or a special sensory cause of hearing loss. We call that sensory neural hearing loss. We can have mixed losses, partly nerve and partly conductive. The typical example will be chronic suppurative otitis media, where this ear, year in, year out, has been the subject of, or the object of disease processes. Finally, we have neural hearing loss. So that's a retrocochlear cause of hearing loss, usually affecting the area of the eighth cranial nerve. And a good example would be acoustic neuroma. In this picture here, we have a T2 weighted MR axial view, and on the right side we have a very large benign growth, an acoustic neuroma. The left side is the normal counterpart. So that would be a neural cause of hearing loss. The history for hearing loss is the same as the history for any part of deductive reasoning in medicine. What is the chief complaint? When did it start? Is it one side? Is it two sides? When did the patient last hear well? In children especially, do you think the child ever heard well in each side? Was it sudden or gradual? Is there pain involved? Is there a family history? There are many other questions which are tailored to the complaint at the time the history is taken. In terms of the physical examination, it's very important to start from outside in. We want to look at the auricle, and I'll have cases to show you in which the auricle is very misshapen, and we have a good idea just in the gestalt of the child that we know the cause. You know, so for example, congenital auricular atresia. We have a good idea that this is an outer and middle ear problem, and the cochlea should be well formed and should be hearing well. And this is usually the case. A very important feature is, can we see the eardrum? Can we see all of it? This is, of course, a cranky, combative child, but it is very important to clean the ear. I have had many referrals for a perforation, a suspected perforation of the drum. And in fact, what has been called a perforation is the edge of a hardened bit of cerumen. So indeed, the ear has to be cleaned at some time. But we want to ask, is the drum normal, or is there some disease in it? Is it perforated? Do we see something out of the ordinary? And I often tell residents rotating through our service, if you achieve nothing other than getting a firm grasp of what is normal, you would have achieved a lot. For example, this is a normal drum. We see all the features, a sharp malleus, we have a suggestion of the incutostapedial joint, we have a shadow where the eustachian tube is starting, the hypotympanum. This lower picture, this is a left ear, and we see a very nice looking drum, except anterior superiorly we see a whitish area which would be picked up by most pediatricians, in fact. This is a congenital cholesteatoma, and very few of these cases are picked up by ENT docs or otologists. What is the level of hearing? So there are many ways to test. In an older child, the whispered voice is a pretty good start. An older, non-cranky child over the age of about 3 can definitely answer properly with a tuning fork test. And we know when we strike the fork, we place it in the center of the forehead, it should be heard on both sides or in the middle. That's our Weber test. This individual is pointing to the right ear, so there's either a conductive or mechanical loss on the right or a sensorineural hearing loss on the left. So the patient's lateralizing to the better cochlea. The retina test should be heard air greater than bone for the reasons I just described, because we're naturally re-amplifying, and certainly an older child can answer appropriately for these tests. We can also test in a booth, a soundproof booth, and we want to obtain several pieces of information. First of all, this is a subjective test. The subject must understand the test and must be willing to cooperate with the test. So, for example, a cranky, hungry child is going to give us whoppingly abnormal responses. It's not even worth trying to test these children. Have them come back on another day when we can get a better estimate of the hearing. But we're going to test by air conduction, bone conduction. We will also do word discrimination, age appropriate, and tests of emittance. So that is how the eardrum moves and also the acoustic reflex, both on the same side ipsilaterally and contralaterally. Again, a child by the age of about 3, 3.5 can do an adult type test. Now, we don't test the whole range of hearing. Humans can hear from about probably below 50 dB up to 20,000. It is simply too time consuming. We select about 250 hertz to 8,000. In a typical audiogram, the nomenclature is universal. So if we learn how to read a hearing test in any country, it's the same. Only the description of the test would change by the language. So circles anywhere are the right ear by headphones. X's, sorry, I pointed to the left, so that's the left ear by headphones. Circles right, X's left. These structures here, these are brackets, so that's masked bone. Facing the right would be the right, so that means we've buzzed out the contribution of the left and we've stimulated behind. We've used a vibrotactile instrument to stimulate from behind on the right. And we know only that right cochlea is hearing. Conversely, on the left, so that's a left bracket opening to the left. That means left masked bone. That means we've buzzed out the right ear and we've stimulated behind on the mastoid. We know only that left cochlea is hearing. This is crucially important. Many children are born with hearing loss, and we cannot really elicit it until they're older. And often they are missed, even with traditional methods, until they're an older child and can have a standard hearing test. Now, just to review, these are some typical patterns on an audiogram. And the upper left-hand corner is normal. Okay, so these are circles for the right ear, X's for the left. These are normal. The normal range is 0 to 25 decibels. The farther down the scale, the worse the hearing. The limit of social acceptability, that is where we can no longer hear soft speech, is about 40 decibels. So if there's a hearing loss in part of the spectrum at 40, we want to do something about that. Vowels are heard in the low frequencies, consonants in the upper. Mid-frequencies, 500 to 3,000 hertz, handle speech, so the telephone and speech. Let's move on. Sensory hearing loss. So here we see a pattern starting normally and going down in the mid to high frequencies. This would be a typical pattern of presbycusis, advanced noise exposure. It could also be a hereditary pattern of hearing loss. Typically that's a cookie bite pattern where it looks like somebody has bitten out the middle of the audiogram, but certainly we could have a pattern like this. This is a pattern in the lower left hand of conductive hearing loss, but this is a special type of pattern. So we see this is a left ear, the X's are air tones by headphones, and our masked bone line is normal except for a little notching right here. We call this the notch of Carhart. So this is a typical pattern of otosclerosis. It is very uncommon for children to have congenital otospongiosis or otosclerosis. We certainly do see it, but it is not common. This would be a typical pattern. Finally, mixed hearing loss. So part of it's nerve, part of it's conductive. So this is a right ear. The circles are the responses by the right by headphones, and we have masked bone, which means we've blocked out the left, we've stimulated behind, and this is our pattern. A typical example would be chronic suppurative otitis media or cholesteatoma. Now, this is for older children and adults. Younger children cannot participate in a subjective hearing test, so we have other ways to test them. And as almost everyone would know, we now have uniform or universal infant screening, which began in 1992 with a Rhode Island project, and now it's in all 50 states. So we use otoacoustic admissions. The cochlea is not a passive conduit of sound energy. It interacts very actively with its environment, and we can elicit this response. It's a very low amplitude, about 4 to 7 dB, but per ear, it takes about 10 seconds to test, and this is a pass or fail test. If there is a response over the 40 dB noise floor, we can pretty much assume that there's audition in the ear. If the child fails, or really the newborn or infant fails, then that means we have to follow the child and possibly move on to an evoked response, which would be an auditory brainstem response. So an auditory brainstem response is an evoked response. It does not occur in nature, as does an EKG or an EEG. We put a sound energy in either a click or a tone burst, and we have to average out competing bioelectric signals, such as the other two mentioned. And this gives us a series of waveforms which are cochlear events and then up the ladder to the cochlear nerve nucleus in the pons, in the midbrain, and then higher centers. And they are age and sex specific. So we have a huge cohort of normals of infants, babies, children, teenagers, adults, and we know based on the age and sex where the individual should end up. We can also correct for known hearing losses. So this is a very good screen. For example, if a child fails otoacoustic emissions, say twice, we would then want to try to do an ABR, and often we don't use chloral hydrate that much anymore. We tend to actually have the child come in and we give them about an hour's worth of general anesthesia, because we can give obtain very good estimates of both air and bone conduction, and we will know with certainty if there is audition or not on either side. Older children, but not yet, let's say a good 3-year-old, we want to use what are called conditioned orienting responses. So this is a good example here. The parent is holding the infant. We have either a sound source, which could be a teddy bear with a microphone in it, or a video source with sound, okay? And the audiologist is behind a glass screen using the controls. So we want to see at which decibel level does the child routinely and repeatedly orient to the sound source. And this is in the sound field. That means both ears. It's not one ear versus the other. It's in the sound field, but it will give us a very good estimate of the level of audition of the child. And really, that's what we want. We want to know if there's even one ear working, that child should develop speech. Older children, as I said before, about 3 years old, probably a very bright 2.5-year-old, they can do an adult-sized, adult-type hearing test with all the parts I've mentioned. For each side, air conduction, bone conduction, emittance, reflex testing, and word discrimination. So we'll have a very good estimate by about 3.5 to 4. But today, with the infant screening, we really don't want to wait that long for obvious reasons. Now, I'm preaching to the choir, but I think it's important to review. Parents know their children very well, and we have to take their testimony. If mom and dad, they will give Mary or Johnny the benefit of the doubt until 12 months. If there's not some effort at speaking at 12 months or beyond, the jig is up and they're in the doctor's office, and they're probably in your office. And I think it's really important to take parents' concerns very seriously. They want to know that their child's hearing, like every other part of the child, is normal or not. And if it's not, they want to know why. So I would say parents, when they bring up the question of hearing loss, we should assume that it's present until proven otherwise. And we have many ways of proving it. So hearing loss occurs, congenital or hereditary, in 1 out of 1,000 births. So it is actually quite common. Early detection is now mandatory. Until 1970, the average age of detection was age 3, very late. The Rhode Island project of universal infant screening began in 1992, and then thereafter, this was based upon their results were taken to the NIH, and a consensus conference in 1993 recommended that this be the guideline for all the 50 states, because the typical child who was fit into the torches category, toxoplasmosis, rubella, chlamydia, herpes, syphilis, when there was a history of torches, this actually missed a lot of children, in fact, too many children. So by the time of the 1993 NIH consensus, we knew at that time only 11 hospitals were screening over 90% of newborns. By 2005, approximately 95%. And pretty much for children born in a hospital or in a birthing center, we want an estimate of audition before discharge. If a child is born at home or not in these venues, then it would be within the first 30 days. So we really want the pediatric community to get involved, especially with otoacoustic emissions. And these are facile, they're easy to do, they're not labor intensive. And if a child fails, we want to know the reason. Maybe there's some fluid medial to the drum or a tough wax impaction. Okay, let's try to get that to clean up and we'll retest that child. These are some references for you, and again, we'll have them available to you. So again, before discharge from a hospital or birthing center, otoacoustic emissions, those who fail, we want to move on to the ABR as described above. Many children with no risk factors are detected to have hearing loss, and especially children with auditory dyssynchrony, that is, auditory neuropathy. And this is a problem of the junction between cochlea and eighth cranial nerve. Often the otoacoustic emissions are normal, but the ABR will be abnormal. So we know the sound information, the representation of sound is not getting past the cochlea, and even though these children may have reasonable levels, they are not developing speech, they do not have word discrimination. Many of these children will go on to cochlear implantation. Let's move on. Congenital and hereditary loss. Well, this is an enormous topic, and I'll mention some very important authors at the end. So this is hearing loss that can be classified as either congenital, congenitata, means at birth, and some conditions are immediately apparent at birth, or hereditary, that is, caused by an abnormal gene. So they're not necessarily present at birth. They may develop later on. Congenital hearing loss is not necessarily hereditary. I'll give you some examples. Hereditary hearing loss is not necessarily congenital. So, congenital but not hereditary. Example, rubella, cytomegalovirus, fetal alcohol syndrome. Okay, so it's not hereditary. It's not caused by an abnormal gene. Hereditary but not congenital. Otosclerosis, not present at birth, almost never in children. Delayed onset, non-syndromic progressive sensory hearing loss. This is a huge category of hearing loss. There's no phenotype to identify the child. We see this hearing loss progress as time goes on. Or Usher syndrome, subtypes 2 and 3. So 1 would be present at birth, but 2 and 3 will develop later on, typically around age 8 or later, and the hearing loss may antedate the pigmentary changes in the retina. So hereditary and congenital. Syndromic patterns, when there's a phenotype involved, such as Waardenburg syndrome, and we'll have a few slides about that, and then non-syndromic patterns of sensory hearing loss, connexin 26 deficiencies. There's several connexins. These are all very important causes of pediatric hearing loss, and many of them will be addressed either with amplification or with implantation. There are 2 references I'd like to bring up to you. Robert Gorlin, who's actually a dentist, and in his sort of avocation is pediatric hearing loss. And in fact, he's extrapolated that to adults. This is a Bible of congenital and hereditary hearing loss. For anyone interested in the field, I would highly recommend this. It's written by really a grandfather in the field, a giant, and I've met him. He's a wonderful speaker and he writes very cogently. And the second one is by 2 colleagues of mine, Anil Lalwani and Ken Grunfast. Anil is at Columbia now. Ken is up in Boston, Boston University, and their book, Pediatric Otology and Neurotology, again, very readable, a very good reference to have. Let's visit Waardenburg syndrome. So Waardenburg was a Dutch ophthalmologist, and around 1951, Pete Waardenburg took care of this young proband, this young girl. her left arm actually did not look like that. That's a Photoshop error. Anyway, she had deafness, and she also had pigmentary changes in her corneae. She also had vitiligo, so you can see she's somewhat albinoid on the top, and she has more pigment in the bottom. But Peter Waardenburg described a whole syndrome, and it bears his name, of children and adults that had certain features: a white forelock, heterochromia iridum, even this is black and white photo, you can see it, and dystopia cantorum. So the inferior lacrimal punctum is shifted laterally at least to the limbus of the iris. This is an autosomal dominant condition. It has variable penetrance. There are other features that are found, such as synophrys, that is the hair of the eyebrows grows together, and there is variable expression. So they do not have telecanthus. So the greater wing of the sphenoid is shifted a little bit, but it's a soft tissue widening of the eye so that the inferior punctum must at least hit the limbus of the iris. We have other things, dystopia cantorum, and there is the retina of the affected side may be hypopigmented. The first medical paper I ever worked on was through the Montreal Children's Hospital, and my professor was Marilyn Pruce. The ophthalmologist on our paper was Robert Palomino, and he detected that these children who were deaf, if it was asymmetrical, the retina on the worst side was also hypopigmented. So here we can see in some of these pictures white forelocks in these children here. This boy on his left side, he has microsomia of this side, which can go, even in the black and white picture, here's a mom and her child, they both have the white forelock, which is real pathognomonic of Waardenburg's. Beautiful example of heterochromia iridum here. So this is the poorer pigmented side. This is an Indian girl. She should have very dark corneae. And here we see the inferior punctum is at least hitting the limbus. It's right on the limbus. And this is something that Dr. Palomino described. This child has heterochromia iridum, and the poorer hearing ear, which is the left, also has a poorer pigmented retina. So it's a bit of albinism. And we can see here from this portion of the slide, indeed, as time has gone on, this syndrome has variable penetrance. There are now 4 subtypes, and even they are subtyped. So this has many, many different manifestations, but it is a hereditary and congenital cause of deafness. Okay, briefly, we'll just talk about infectious and inflammatory disease. Again, a huge condition. Every pediatrician listening will take care of children that have acute otitis media and also serous otitis media. And one big question is, for Mary or Johnny, when they're young and they've got persistent fluid, let's let their fluid stay in for 6 to 9 months, and it's just not clearing. Maybe they have big adenoids. Are we doing a disservice to this child by not clearing out the middle ear cleft? In other words, do all these children need to have tubes? So Jack Paradise and others looked at this very issue, and they studied a very large cohort of young children who were enrolled in the study at birth. So they enrolled over 6,350 children from birth. Now, of course, all these children did not go on and have persistent serous otitis media, but about 430 children did, and they were followed very carefully. Okay, so one group went on to have tubes, the other group were observed. Okay, and after 9 months, they're either tubed or observed. They measured the later developmental skills of these children, of these 2 cohorts, and they had about a 91% follow-up rate. Now, they looked at a huge number of things, 48 developmental measures compared prospectively and in a randomized fashion between children with early versus delayed tubing. And in fact, there was no difference in their outcomes. So I think this is a robust study. It's prospective, it's randomized, it's done by a very respected person in our field. He's a pediatric otolaryngologist. And indeed, so I would say there's not really a push or an emergency to put tubes in these children. Certainly, if a young child in the learning situation is doing poorly in school, it would be very reasonable to drain the fluid. Okay, cholesteatoma. Again, a huge topic, but let's just narrow it down a tiny bit. Most of our cases of congenital cholesteatoma are actually referred by pediatricians. Very few are picked up. So, that's a little bravo from me to you, because certainly our pediatric, our pediatric professionals know what to look for. They're not bypassing these. And indeed, along with everything else, they're looking at the ears of these children very critically. Now, we classify cholesteatoma, which is a skin cyst, into congenital and acquired. So primary means there has been no manipulation of the drum. In other words, it's not fair if the kid had a tube put in and later on develops a cholesteatoma or had a perforation. That's not fair. So we don't countenance that. There must be no antecedent manipulation of the drum, either by nature or by a doctor, and it's due to a primary retraction of pars flaccida. So that means the part of the drum superior to the anterior posterior ligaments of the malleus, due to eustachian tube dysfunction, that has sucked in and formed a cholesteatoma. Secondary would be through a pre-existing defect in the drum, either perforation or a tube or something like that, okay? And indeed, cholesteatoma in broad strokes is a surgical disease. There is no medical treatment. You can give as many antibiotics as you want. If a child has a cholesteatoma, ultimately that cholesteatoma is going to have to be addressed surgically. Putting a tube in will not prevent the growth of cholesteatoma. And here's a good example. Well, this is just some squamous epithelium. That's the product of what we get. Here's a young boy. He was about 18 months when I saw him. In the sound field, he has normal hearing, but this is sort of the tip. This is a left ear at surgery. This is the tip of the iceberg. He had a huge congenital cholesteatoma. He had actually a canal wall down, tympanoplasty with mastectomy. It was the only way to control this disease. So it can be rather deceptive. What we see in a drum, if some people, the old teaching was, if you see a light reflex, it's okay. Well, I can tell you that is not true. You can have an adequate retraction cholesteatoma and a beautiful light reflex in the same ear, so that you cannot really use those old, proverbs as your guideline. Our goals are very clear. A safe, dry ear, an ear that can be toileted in the office and can be cleaned, however we have to achieve that. And secondly, the same or better hearing. We never use the word normal. In fact, that word should be stricken from the vocabulary when discussing cholesteatoma with a parent. It simply is not possible. When an ear has reached that level of pathology, we know there is severe underlying eustachian tube dysfunction, and we're not going to go back. We're not going to make that ear into a normal ear. We want to render the ear safe and dry so an ear will not get into trouble, will not cause erosion of the otic capsule, of the facial nerve, even of the brain. So we want to be very careful about that. Okay, let's move on to a very favorite topic of mine, congenital auricular atresia. So we talked briefly about the embryology, but that's great when it works out well. So in the beginning of month 7, the outer ear, which has filled up with mesenchyme, that has to start to involute. And this is a common theme, especially in the great vessels of the heart and the urogenital tract. So failure of involution can cause lots and lots of pathology. So indeed, in the ear, if that auricle, the external canal, fails to involute, we will have both a soft tissue and a bony atresia. It is sometimes found in certain conditions such as midface abnormalities, Pierre-Robin malformation, other Treacher-Collins syndrome, others, but most of our cases are sporadic. Most of our cases there is no family history and both parents are normal and they're not related by their lineage. They're not first cousins or anything like that. It's a spontaneous event. So again, because this is an outer and middle ear cleft problem, both the soft tissue and bony atretic plate, the malleus and incus are fused and clumped and attached to the tympanic ring ordinarily. The stapes may or may not be present and or mobile, but the otic capsule, that means the inner ear, because it's of a different origin, it's ectodermal derived from near the neural crest, it will almost always be normal. So it's very rare that we have abnormalities of the inner ear. This is an outer and middle ear problem. So let's take a look at this young lad here. He was born, his name is Eric. He's now in his early 20s, but he was really born with no auricles. He had very misshapen ears. We use grades 1, almost normal, 2, has auricular appendages, 3, vestiges, maybe a lobule, maybe a tragus, very little. 4 would be anotia, nothing at all. So he was pretty much a 3 on both sides. My colleagues in facial plastic surgery recreated these auricles using costochondral, rib cartilage. Now, he wore a Baha on his right ear since about the age of 10. In fact, at this time, and we'll talk about Bahas, this kid sweats a lot, and I would actually have to mail it back to Gothenburg, Sweden to be fixed, and then it would come back. So he was off hearing for a long time when he would inactivate them. Thank God the Nobel Pharma had a U.S. office in Englewood, Colorado, so we could get them back and forth in a couple weeks as opposed to 6 weeks. But when he was a teenager, he decided that I offered him another Baha on the left side, bone-anchored hearing aids with vibrotactile, but he wanted to try to get his ear opened up. So we did. We opened up his ear. We recreated an eardrum. We checked out his ossicular chain. Actually, it was pretty good, very favorable. Rebuilt him an eardrum. And then in the area near the anterior iliac spine on the right side, we always use the same side, we took some thin strips of skin, which you can see here. These are about 8/1000ths of an inch, and we put some silastic backing on them. The dermal side goes down. So long story short, here he is, his right circles of the right ear. He's down at a maximal loss of 60 dB with about 88% to scrim. Lo and behold, he closed up to about 25. I was not expecting that. But he still has a Baha as a backup. Okay, so that's, and I must tell you, even Babe Ruth did not hit a home run every time he got up to bat, and neither do we. We know these cases are not always successful. Okay, here's a young lad, he's 10. He came to me actually first when he was 4.5, and he was a bit of a hellion. He did not like Dr. Linstrom to examine his ears or clean them. He has a small, sort of imperfect atresia on the left side, which was operated upon by a physician up at Columbia. But here he is. He had this auricle restored by a very famous surgeon,